I welcome you all to today's session, pit and fissure sealant. So first, you have to know what is a pit and what is a fissure. Pit are small pinpoint depressions located at the junction of developmental grooves or a terminals of those grooves, whereas fissure are long cleft between the cusp or the ridges. These regions always provide a region for retention of caries producing agents. So first, to begin with the history, actually, pit and fissure sealants application were attempted early in the 20th century at the beginning itself. In 1905, the application of silver nitrate by Miller. 1923, Hyatt published the term prophylactic odontomy, where he advocated the filling of fissures of teeth with silver or copper oxyphosphate cement as soon as the tooth erupts. In 1929, Boddacker suggested widening the fissures mechanically so that they would be less retentive food particles and also called it as fissure eradication. In 1955, Monaco introduced a method of adhering resin to an acid-etched enamel surface. Followed by in 1962, Bowman and its associates developed the bis-GMA resin, which is the chemical reaction product of bisphenol A and glycidyl methyl acetate. So sealant is a thin plastic coating material applied to the chewing surface of the posterior teeth, which prevents caries. The classification of different type of pit and fissure sealant materials used begins with the classification introduced by generations, the first, second, third, and fourth generation. The third generation is the generation where 470 nanometer wavelength blue light was used to cure, which was improved with fluoride releasing particles in the fourth generation. The other classifications include filled or unfilled, which is the presence of filler. The filled sealants have a high wear resistance. Their ability to penetrate into the tissue is low. The unfilled resin sealants, on the other hand, have a higher viscosity and provide greater penetration into fissures and better retention. Based on the translucency, opaque and transparent material, the opaque material can be white or tooth color, and the transparent sealants can be clear, pink, or amber. Based on the morphology of pit and fissure, Tagore described four types of fissures: U type, V type, I type, and K type, where V and U are shallow and wide and tend to be self-cleansing, where the I type is deep, narrow, and wide constricted, and the combination of both, where the caries are more susceptible. So, how does this pit and fissure sealant work? They obstruct pit and fissure, which prevents lodging of fermentable carbohydrates and colonization of bacteria. The indications and contraindications. A sound pit and fissure should be sealed. Deep, narrow pit and fissure should be sealed. And the contraindication is carious pit and fissures should not be sealed. And the teeth, which is free of caries for more than 4 years, should not be sealed. The major advantages: non-invasive technique. The fluoride sealant can prevent caries. It can be used at the community level. The major disadvantages: it is technique sensitive and it is a lack of universal usage. The armamentarium used in pit and fissure sealant are mouth mirror, explorer, tweezer, pit and fissure sealant, enamel hatchet, light curing unit, pumice, prophylactic brush, articulating paper, and sealant polishing cups. So the technique will be discussed right now. The first thing to do is the time to seal. That when the sealant should be sealed, it is the very first thing to think. The first procedure that is started is polishing the tooth surface. It is absolutely necessary to remove plaque and debris from the enamel and the pits and fissures of the tooth. Any debris that is not removed will interfere with the proper etching process, and the sealant penetration into the pit and fissures will be disrupted. Once following the polishing, isolate and dry the tooth surface. So isolating is the most important clinical procedure that will be followed in pit and fissure sealant. If the etched enamel get exposed to salivary proteins for as little as 0.5 seconds, it can be contaminated. The use of rubber dam is the ideal way to achieve optimum moisture control. Four-hand technique facilitates sealant placement and is also associated with improved retention. The acid etching will be followed by that. 37% phosphoric acid will be used. The concentration, if it is higher, it might lead to reduced clinical effectiveness. Usually the acid etching follows to 20 seconds of time, followed by washing and drying, a rinsing of 30 seconds, followed by pressured air application for 15 seconds. Usually the three-way syringe that is free from oil and water will be used to dry the surface, which will give a chalky white appearance. Once it is isolated and dried, the application of sealant begins. Once the sealant is applied without any interruptions, it will be light cured for 20 seconds. We will apply and seal it. So these are the procedures. The preparation of the tooth surface by polishing using a pumice, followed by isolation of tooth, rubber dam application, acid etching, followed by isolation. Once washing and drying, the frosty white appearance, followed by the sealant placement and polymerization. Once it is done, the occlusion should be checked and adjusted if required. So the patient should have a frequent follow-up to observe whether the applied sealant is retained or not. The patient should be educated what all should be consumed after the following sealant application, and the sealant should be evaluated at every 6 months.